Okay, so pericardial effusion, I think we're good with, the fluid that gathers between the pericardial sac and the heart leading to that pressure. So what's that going to do to end diastolic volume, though? What's it going to do to it? Is it going to increase or decrease that? Oh, that's a tough question, isn't it? Yes, very good. So pericardial, so let's look at a picture, okay? You can see that pericardial sac, that glad bag that's around the heart, right, doesn't give. I mean, it is solid, okay? When you look at it on a cadaver, or even a cat, you could see it, if you've ever dissected a cat. So you could see the pericardial sac around the heart. If there's some sort of infectious agent or irritation or fluid, right, that's backing up into it, that fluid is not going to stretch the pericardial sac. That fluid will fill the space and push on the heart. So if you're pushing on the heart, you're simply decreasing the ventricular volume, aren't you? So you're going to decrease end diastolic volume. This is, sadly enough, this happened to my dog. My dog had a tumor. I don't know what type, because they didn't tell me and I didn't really want to know. That caused this effusion around her heart. And she had the Beck's triad, the pathognomonic signs. She had decrease in arterial supply. So her paws and her extremities were cold, right? She would have been blue if you could have seen her skin. Obviously lacking energy, but she also, those aren't the Beck's triad. Beck's triad's back up here. So she had decreased arterial supply. She also had distension of the jugular veins. Because think about it, if you cannot get fluid into the heart, it's got to go somewhere. If you're not getting in, it's going to back up. Okay, it's going to back up. You're going to get that jugular vein distension, muffled or distant heart sounds, which are for obvious causes, right? Because you're listening to it through the fluid. Okay, so cardiac tamponade is going to be that high pericardial pressure, which will inhibit that returning of blood, decreasing end diastolic volume. Okay, Beck's triad is the signs and symptoms of that. Okay, any questions on that? Pericarditis is going to be an inflammation that's caused or happened in that pericardial cavity between the sac and the heart. Now think about it back from when we first got together, okay? Inflammation sets in, macrophages come in to eat it up, fibroblasts come after it and deposit fibrin to help begin that healing process. Well, it goes awry in this process, doesn't it? With pericarditis, inflammation sets in, the macrophages come in, the fibroblasts come in and set down fibers, and you get a fibrous scar tissue. And you could get those friction rubs, okay, that you can hear. So it's a normal healing process that's kind of gone awry a little bit, okay? Does that scar tissue go away? No, it stays there. Okay, so there's that. I think that's a great picture. And it gives you a good visual. Okay. Any questions on that? Okay, myocarditis, you could pretty much read through that on your own, right? It's going to be some sort of infectious agent that gets into the heart, okay? Do you guys mind if I bump through some of this? This is all great, okay? Endocarditis is going to be inflammation or infection that affects the inside of the heart. This is dangerous though, right? Because you get turbulence. You're going to get a deposition of material called a vegetation. Primarily, it's going to end up on the valves, right? The tricuspid, bicuspid. More bicuspid. Why more bicuspid? Because there's more pressure, right? More pressure, more turbulence. Okay, can it happen on the tricuspid? Sure. Okay, but it tends to go on that bicuspid more often. Okay, forms that vegetation. That vegetation can attract blood clots. Okay, we could throw those blood clots. Now, this is where that whole thing they were talking about with people who have mitral valve prolapse, taking the antibiotics, right, to prevent infection from getting into the heart, causing this endocarditis and throwing clots. Now they're changing that for some reason. People who have any periodontal work, they're saying they don't need to take the antibiotics now. I would want one personally. I'd probably go to my nurse practitioner and say, hook me up. But I don't know what the studies are. My thought is, why not, I don't know, but that's my un asked opinion. Okay, so signs, symptoms, I mean, anything that you would think with infection, changing valve sounds, right? Heart problems, okay? Subacute endocarditis can be seen with like rheumatic heart disease. My mother had oh, why am I drawing a blank? Not rheumatic disease when she was young. What's the one that causes mitral valve? Scarlet fever, thank you. Yeah, she had that as a child, and it damaged her mitral valve. So people with recurrent strep infections too, you know, any of those infections can get into the blood and can affect those valves as well. Okay. Any questions on that? Good. Okay. So here, if you could flick the lights for me, I want to show this to you. Okay, here is normal for a couple reasons. I want you to see normal versus abnormal. But the other thing I want to show you here, I'm going to try to walk you through using my voice so people at home can see this too. We're looking at the normal AV valves. So you've got with bicuspid and tricuspid, the flaps themselves, either 2 or 3, right, depending on whether it's bi or tri. But you've also got cords. Remember those chordae tendineae? Okay, and those chordae tendineae come down and insert onto those papillary muscles. And the whole purpose of those chordae tendineae is to prevent the valve from going into the opposite direction. Okay, so when that valve closes, it closes and it doesn't go beyond that closed position. Okay, with rheumatic fever, with scarlet fever, with an endocarditis, you know, any sort of infection, you can damage the valve itself, but you can also damage these chordae tendineae and the papillary muscles. So they aren't as efficient at keeping that valve from over opening, if that's a word, and keeping them in place. So those valves, as well as those other structures, can be affected. Okay, so papillary muscles are those little finger-like projections, and the chordae tendineae are the strings. They're your heartstrings, you know, that people talk about. Okay, so normal versus, look at all the vegetation on those valves. Yeah, it's quite amazing what can happen. One more time. Normal. Abnormal. No, this is obviously progressed. You know, this is not going to be like a simple, yeah. This is, well, obvious what happened, you know, so, okay. Okay, so stenosis versus incompetence. Are we pretty good with this? Yeah, okay. So stenosis is going to be a narrowing, okay, as opposed to incompetence is going to be either the valve is a little bit misshapen and doesn't close properly, or those chordae tendineae or those papillary muscles are not sufficient at their jobs, okay? So mitral and aortic are two of the most common. And once again, they're going to be the most common because it's on the left side where we're going to have higher pressure, higher intensity. Okay. Am I going too fast? This is all pretty bread and butter stuff for you guys, right? So I'm going to kind of go through. Rheumatic heart disease between 5 to 15 can follow strep. Multiple strep infections can cause this as well. It can affect anywhere in the heart. Okay, ischemic heart disease. So we've gone through all the steps that lead us to ischemic heart disease. Okay, so inflammation, deposition of plaque, thrombus formation. Okay, eventually it's going to widen enough where it's going to block the vessel, and you're not going to have enough blood beyond that point. Okay, so it depends on what vessel gets into, doesn't it? If it's a teeny tiny distal vessel, it's not going to be a big deal. The heart will form scar tissue in that area, and the heart can keep functioning. But if it's going to be a big clot in one of those big coronary arteries, it's a problem. Okay, so it depends on where it is. So chronic is going to be a slow progressing, acute is going to be quicker and fast. And with acute, from that little video that we watched, acute is a lot of times the rupture of the atheroma. Okay, and all that material comes out, it attracts platelets and thrombin to it, okay, and fibrin, I'm sorry, not thrombin, and it forms a clot. Okay, so acute versus chronic. And endothelial tissue, we talked about that already. Okay, so here's a nice little picture of the carotid artery with fat. I don't know, I don't think you need to turn that off for right now. I think we can sort of get the gist of that. But it integrates itself into that lining of the blood vessel. you know. Oof. Oof. Okay, and here's a closer look at it. So we're looking at a cross section. Hi, Steve, I'm all set. Thank you. A cross section of that, and you can see those different layers. So we're looking at fat that's been invested in that smooth muscle layer there, and either the smooth muscle cells themselves or macrophages have gotten invested in there and brought fat into them, okay? And basically turn to little fat cells and build up that nice little plaque, damaging the inside of that blood vessel. Okay. Angina. So angina is going to be that chest pain. Okay, could be variant, could be unstable. Now, angina can be caused by blockage of vessels, but you can also have spasms of blood vessels. Okay, they can cause problems as well. This is my sister-in-law has this, and no blockages, no hardening. She just has spasms. Quite often contributed. Unfortunately, she smokes, even though she tries to hide it from us. And also stress. Okay, so what she needs to do is quit smoking and stuff with the stress. But quite often, people with angina will have a good response to nitro unless it's becoming unstable. Okay, and that means it's progressing to the point where there's probably enough blockage not to get enough blood through anyway. Okay. What are the typical referral patterns? Who's had the weirdest referral pattern? Women, right? A guy I dated in college, his grandmother was having a heart attack. She called her doctor, and said, I think I'm having a heart attack. She had like a gallbladder referral pattern, like shoulder blade. It's like, no, it's probably gallbladder. I'll see you tomorrow. She's like, no, I think I'm having a heart attack. And she only knew it because she was reading Reader's Digest and about how women have atypical presentations. So I love my nurse practitioner because she's like, why would you just not test somebody who has, you know what I mean, being like that. I love you guys, by the way, nurse practitioners. Okay, so fatal arrhythmia from myocardial ischemia. Have you guys learned about ectopic foci? Okay, let's go through. Do you remember the conducting system of the heart? Okay, we've got SA node. Let me just write this on the board in case there's anybody at home that does not. Oh, I gotta clean that up. Ugh. Forget how much I write sometimes. So the whole premise behind contractions of the heart is that electrical current, okay? That's why if somebody goes into VFib, what do? Shock them, right? Because you're trying to reset it so that electrical current can become normal again. So if we're looking at, the heart here, we've got SA node, right? Sinoatrial node, sinus rhythm, right? That will send the signal through both atria down to the atrial ventricular node. Okay, so it's starting to ring a bell now. Okay, then we've got bundle of His. God bless you. God bless you. Right and left bundle branches. And then these bundle branches sort of swoop back up the sides of the ventricle in what are called Purkinje fibers. Okay. So the electrical current starts with the SA node. Okay. Sets the rhythm, of the heartbeat. Sends it down to the AV node, which transfers the signal from the atria to the ventricles. That's why it's called atrioventricular node. Sends the signal down through the bundle of His, bifurcates into the bundle branches, and that scoots back up by Purkinje fibers. So that way we get atria, ventricles, atria, ventricles. And it's a very linear progression. So that way we make sure that we don't get out of sync and start contracting ventricles and then atria. That wouldn't work, okay? So what can happen in the heart when we get damage to it is we can get an area, I'll just put it over here, of cells that become the pacemaker. Their signal is stronger than the SA node, and they pick up an atypical pattern. It can either be tachy or bradycardic. I think it's more often tachycardic. Okay. That abnormal signaling of the heartbeat is called an ectopic foci. It's going to be generally an area that's going to be damaged because of myocardial infarction. Okay. You can also get an ectopic, I think it's right in the notes, right? Yep, ectopic foci. You can also get an ectopic foci if you drink a lot of coffee, smoke a lot of cigarettes, okay? But that's transient. So ectopic foci. So, sudden cardiac death. So a fatal arrhythmia can come from one of these ectopic foci. Okay, they can set an abnormal rhythm. Our heart is meant to beat in the range that is normal, right? 60 to 100 beats per minute. If we get out of that, we can't get enough blood back and out. We also get more turbulence, so we can throw clots. Okay, so this ectopic foci can become a problem. Are you with me? Okay. So fatal arrhythmia from myocardial infarction can be caused by this ectopic foci. Okay, cocaine has a lot. This was just a little note. We'll zoom in for people at home. Okay, cocaine can cause a transitory coronary artery constriction coupled with increased metabolism demand of the heart. So, you know, people who, if you've ever seen people come in who have gone on a real bender with cocaine, well, they can have heart damage because this is directly affecting the heart. Okay. Acute serine enzymes. Now, this I didn't know. The two above I know. Creatine kinase. I did not know about the troponin. You guys know about this? Okay, I did not know about this. This was new for me. Troponin is actually a chemical structure that helps with the contraction of that heart muscle, and it will peak after myocardial infarction. And they can test it in the blood. I guess it's becoming a more commonly used blood test. Okay, so that's pretty cool. Okay. So troponin actually, speaking from an anatomical normal ANP view of it, helps with that overlapping of the myofilaments in cardiac muscle cells. It's a normal substance that helps them to contract. So when that heart muscle is damaged, it's released into the blood. Okay. And I guess the reason they like it is because it can be measured at 6 hours after an MI up to 10 days. So it's a pretty good measure of damage to the heart muscle. Okay. Kind of cool. Treatment, coronary bypass. There's two vessels that can be used. Greater saphenous. Do you guys know where the greater saphenous vein is? Okay, I'm seeing some yeses and some nos, or some no responses. Maybe people are just so tired. Greater saphenous vein is going to drain the entire inside of your leg. So it's a nice, accessible, long vessel that they can pull out. There's enough collateral venous return that you don't really need it, okay, if it's taken out. And it's also a nice long specimen, so they have several, parts that they can use. The cool thing about that is when they implant it, it will actually change from a venous vessel structure to an arterial. The body will actually transform it so it becomes stronger and thicker and more able to handle those stressors of blood being pumped. Okay. Internal mammary, do you know where that one is? Internal mammary, if I were to take off my breastplate, okay, cut this out, and we look at the inside of my sternum, that's where my internal mammary runs. It comes right off the subclavian artery, straight down on either side of the sternum. So it's pretty cool because they don't have to pull a vein. They can just pull that internal mammary and just tap it to wherever it needs to go. Pretty neat, okay? And why would they use Teflon material? Now that we've talked about doesn't clot, because there is no what? And there's no, how did we talk about it in here? There's no turbulence, right? There won't be any buildup of material on the inside of it because it's smooth, so you won't get that turbulence. Good. Okay. Percutaneous transluminal coronary angioplasty, catheters inserted, stents, we're all familiar with this. Intra-aortic balloon pump, are you familiar with that? This was pretty cool. I pulled this video up for those who may or may not be familiar with it. I'll back it up because I also really like this guy's voice. Or maybe it's the other video. Is this not? Which one's not new?
A mechanical device that consists of a cylindrical balloon that sinks into the aorta and counterpulsates. It actively inflates in diastole, increasing blood flow to the coronaries, therefore increasing coronary oxygen delivery. It actively deflates in systole, decreasing surrounding pressure, therefore reducing afterload. That leads to increased forward blood flow. These combined actions result in a decreased myocardial oxygen demand and increased myocardial oxygen supply.
Okay, let's go over that and watch it one more time. What happens is the coronary arteries will fill during diastole. Okay, so the coronary arteries fill during diastole. So this balloon pump will actually open during diastole, pushes the blood back into the aorta so it can be pushed into those coronary arteries. Then it relaxes during systole, so it's not in the way of blood being pumped out. So that being said, let me play it one more time. Uh-oh. Wait, where'd it go? Okay, let me just do this again.
The intra-aortic balloon pump is a mechanical device that consists of a cylindrical balloon that sinks into the aorta and counterpulsates. It actively inflates in diastole, increasing blood flow to the coronaries, therefore increasing coronary oxygen delivery. It actively deflates in systole, decreasing surrounding pressure, therefore reducing afterload. That leads to increased forward blood flow. These combined actions result in a decreased myocardial oxygen demand and increased myocardial oxygen supply.
Okay, that makes more sense that time. So amazing. How do people even think up this stuff, let alone implement it? Okay, so TPA, what's TPA? Tissue Plasminogen activator, okay? So it needs to be administered pretty quickly, within 4 to 6 hours, somewhere in there, okay, to break up blood clots. Plasminogen, when activated, will turn into plasmin, will go in and break clots up. It's a normal substance that we have in our body, but they'll administer high levels of it to somebody who's thrown a clot, okay? Here is, now how many pictures do we have? You can turn off the lights if you want. Okay, so here's a picture of a bypass. Okay, so the coronary bypass, they'll take it and they'll tap it right into the aorta and bring it down beyond that point where the blockage is. Okay, it's pretty amazing. And it is pretty cool to see it. If you were to actually touch it, it would feel like an artery. So it does create that transition from more of a venous presentation to an arterial presentation. Pretty cool. It's amazing to think of this stuff that they do, like people just never would have lived, you know? Okay, picture of a stent. Okay, the catheter placement, and then the stent is expanded. I've also seen stents that are more like a basket type presentation. I don't know the names of them. Once again, I don't deal with things like that. But in larger vessels, I've seen stents in place that look more like a basket, which are pretty cool. Okay. Effects of MI, arrhythmias. Okay, so VFib we talked about, defibrillation we're going to use to try to reset that. What will be the first organ beyond the heart damaged by this disease process of lack of blood supply? Who's going to be the greediest for oxygen?
Brain.
The brain. Okay. Cardiogenic shock is going to be a lack of enough blood to perfuse the tissues. That's exactly what was happening with my poor little doggy. She didn't have enough blood getting into her heart to get back out. So she was, cold, and she would have been blue if I could have seen her. Thrombosis, we've talked about that. And rupture, the heart tissue itself, if there's a massive MI, it's not normal heart tissue. Don't forget that heart tissue does not regenerate, right? What's going to replace those cardiac muscle cells? Scar tissue. So if it's a massive, massive area, you're going to have massive scar tissue. It could rupture. So, congestive heart failure. So, Myocardial weakness due to damage from that infarction. It's going to restrict the ability to pump and for those valves to be effective. Okay. It could be that pericardial pressure from the scarring in that pericardial region. Okay. Increased afterload from hypertension. We kind of touched upon all of this. So if we have all these processes, are we going to be able to get blood in and out of the heart effectively? No. Okay. The heart is going to start to fail. We can get congestion. We went through this whole right versus left side. If we have right-sided heart failure, where is the congestion going to manifest?
Body.
In the body. If we have left-sided, it's going to manifest in the lungs. So either you could have a pitting edema or you're going to have some sort of respiratory compromise, right? Okay. So that would lead to dyspnea. Sorry, I almost said dyspnea. Dyspnea. Okay. Why do patients have cardiomegaly? Cardiomegaly. I'm starting to get tired. I'm sorry. Towards the end of class, I start to lose my vocabulary. Why are they going to have cardiomegaly? Absolutely, the heart's trying to pump harder. Okay. We talked about hepatomegaly and splenomegaly. We talked about that as well. Okay. So you could have similar effects. Port pulmonale is going to be right heart enlargement as a result of some sort of pulmonary hypertension or damage. Okay. Chronic bronchitis. When you're talking about bronchitis and when you're talking about emphysema, you're not going to have normal lung structure. You're going to have scar tissue or a lack of that tissue. It's going to be more difficult to pump blood through those pulmonary vessels. Well, if it's more difficult, it's going to back up into the right side of the heart. Are you with me? If it backs up in the right side of the heart, that right side of the heart is going to start to do what? Try to pump harder, and it can enlarge a little bit. Okay. Are you with me with that system? See how if you understand the whole process, it's pretty easy to backtrack to what happens. Okay, so right heart enlargement is a result of that pulmonary hypertension. Pulmonary vessels become damaged, there's increased resistance, that fluid backs up. Any questions thus far? Oh. Here's a picture of it. So, myocardial dilatation is going to be a stretching of that heart muscle, making the chambers bigger and thinner. I have a picture of this. Once again, if you're stretching it, it's that same premise that we talked about earlier. You're not going to have overlapping of those cardiac myofilaments. They're not going to contract as well. Hypertrophy is going to be an increase in those muscle cell size. So it's going to be thicker. Okay? And you can have a little bit of both. Now you can see the difference. I don't think, do you need to turn off the lights to see that? You guys can see it okay, right? Okay. So, here's normal. Here's the expansion. Here's the hypertrophy. So you can see the difference is the heart's going to be larger looking from the outside, but obviously we're going to have thinner walls or we're going to have thicker walls. Okay. Restrictive is when we get more scar tissue in there and we can't contract the heart as well. And there's not going to be as much expansion as well either. Okay. Any questions on that? Good. Okay. So some words on medications. We sort of talked through ACE inhibitors, beta blockers, nitrates or nitroglycerin. We'll release that nitric oxide that we spoke about before. Calcium channel blockers we talked about already. So there's a little bit more about those. Congenital heart defects. So here, are you guys familiar with these? Ventricular, atrial, yes. Patent ductus arteriosus. Yeah, sort of kind of tetralogy of flow. Okay. So congenital heart defects, things that people are born with. Some are going to be things that people cannot live with. That'll have to be surgically fixed. Atrial septal defects, people can live with forever, depending on how big it is. Now, atrial septal defects are going to be primarily that patent foramen ovale. Okay, patent foramen ovale. So let me bring my people at home in a little bit here. Okay. If we're looking at the heart, the embryological heart, and if you'd like to review that video that I gave you a long time ago, does not need to send blood to the lungs for oxygenation, blah, 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 right? Okay, it bypasses the lungs. One of the ways it does that is between the right and the left atria. There's something called the foramen ovale. Okay. Also, between the pulmonary trunk, so in the heart itself, so if we're looking, if I were to try to draw the heart, which I'm not going to really do well, and we're looking at the front of the heart, we have the pulmonary trunk, okay, and the aorta kind of crosses right behind it. Between them, there's a vessel called the ligamentum, or the ductus arteriosum. So once again, we bring blood into the right side of the heart. Either it goes from the right atrium to the left, or it goes into the pulmonary trunk. Instead of going to the lungs, it goes right to the aorta. That way we can bypass the lungs. Are you with me? Those shunts? Yes? No? Kind of? Okay. If it's not, just go and review it and talk to me later. So we're bypassing the hearts. Now, if a child is born and things happen like they should, they take their first breath, intrathoracic pressure increases, these shunts close, okay? If a child is born and there's a bit of a problem, these can remain open, okay? So they're called patent ductus arteriosus, which is right in your notes, or patent foramen ovale. If it's small, it won't be a problem. If it's pretty big, it's going to be a problem because you're going to be mixing right and left-sided heart blood, okay? So, ventricular septal defect is going to be a problem too, okay? Ventricular septal defect will be a problem because you'll be mixing blood in the ventricles. Between the atria, if it's pretty small, people can live with that pretty quickly, or pretty readily, okay? In Tetralogy of Flow, we'll go through there's various things with that. Okay, so Tetralogy of Flow, can you guys read that okay in your notes? Did it come out okay in the printed notes? Okay, so multiple things, oddly enough with these patients, they have multiple problems. Okay, oh, my people at home, let me bring you in closer. Okay, you're gonna have a thickening of the right ventricle because it's actually gonna pump into the left ventricle. There's a ventricular septal defect. There's the aorta actually can come off both ventricles. So you can see how that would be a problem, right? You're not going to have deoxygenated blood being sent to the lungs and then back to the left side of the heart. You're going to have a mixing of blood in those ventricles from both sides. Okay, coarctation of the aorta is what that is called, when the aorta comes off both the ventricles. Okay? And then narrowing of the pulmonary valve, which is the least of their worries, right, with the other things. So multiple things. Mostly the problem is going to be the opening between those ventricles and leading to, both of them leading to the aorta. Okay? Coarctation of the aorta. C-O-A-R-C-T-A-T-I-O-N. Coarctation of the aorta. I wouldn't ask you that word. I would ask you the concept of the aorta opening from both ventricles. Okay. So Tetralogy of Flow. So I gave you that one. You give me this one. What's happening? What condition is this? In an adult heart. Out of those conditions I just gave you. This is a tough one. Very good. You could see that connection. This is a much better picture than I drew, huh? Sorry. I can't draw. You could see the arch of the aorta. You could see the connection between the pulmonary trunk and the arch of the aorta. That's the ductus arteriosus. That should, upon birth, close. That ductus arteriosus will take the blood from the right side of the heart directly to the aorta in a fetus or a baby that's not been born yet, okay, bypassing the lungs. So this would be a patent ductus arteriosus. Very good. These should be pretty easy. Okay. What condition is this out of what we talked about? Atrial, right? I would write down or circle the patent foramen ovale. That's going to be the most common atrial septal defect, I think, that you would see. Maybe I'm wrong. Okay. There's a membrane that when a child is born just flaps down, okay, and closes that opening between them. It's not uncommon for that to stay a little bit or pretty open. And if it stays pretty open, what condition do we see in babies? It's a real common name. You know, like people who don't even have any medical background. They would be blue baby, right? They're going to have that opening between the two atria. They're not going to be able to get all that oxygenated blood out to their body, and they'll start to turn bluish if it's really open. Okay. What condition is this? Did I put 2 in? I put 2 in, didn't I? Same thing. What condition is this? That's what I thought. I put in an extra picture. Ventricular septal defect. Just a little note that ventricular septal defect tends to be high. See how high it is? It's right where the atria and the ventricles meet. That little bit at the top of the septum between the ventricles is a membrane. So other than that tetralogy of Flow, there tends to be a propensity for that opening to be where that membrane is at the top of that ventricular septum. Okay. Woo! I flew through. Sorry about that. I'm sure you're not sorry. So that is cardiovascular. And I should have respiratory, like I said, done by, gosh, Monday. Monday night it should be loaded. The final is going to cover, if you go to like that list in the, hold on a second. Angel, from central nervous system through respiratory. It's not going to cover GI. It's not going to cover reproductive. It's not going to cover KB.
One more quiz, and then we'll have the final.
Oh, no more quizzes, I don't think. Unless you really want one.
Well, there's the cardiovascular.
Well, yeah, there's the ones that I've uploaded.
Okay.
Yes. I uploaded, there's endocrine, there's cardiovascular.
We're not going to have a quiz on the respiratory because it's going straight on the final.
Right. Yeah, I figured we'd hold off by now, and I'll try to get the final done as quick as I can.
75 questions again, or?
Yeah. So not on these 3. So we will have CNS. So 1, 2, 3, 4. Whoops. 5. So probably 15 questions per chapter, I would think. Is that? Yeah. Because 15, there's 5 chapters, 5, 10, 15, 75. Yep. So 15 questions per chapter. They should look similar to your quizzes, but there will also be new ones. I don't know, I think that's it.
Up all the way so your clock isn't over the question again.
Yes, guys,
I was
if you
looking at it, it
come
doesn't make sense, and then
to hear,
Yeah, that's what I did.
Yes.
I was like, I can't.
for people who, I think I
because
sent
the
out,
question had a timer over it.
I sent an email out about that, right?
And then I figured
Okay,
it out and then
yeah, just open it up. Yeah, I think that's it, right? And then you're done. Yay! You guys have been fun. Thank you. Like I said, I'll have respiratory by Monday night. I'll have the test open by Tuesday, if not before, if I can. And I think the class is open till the 20th.
Now, did you say that if,
Think.
this is what I was asking on the break too, that if we copy down all the links to the screencast, we can actually have access after the
I
class?
believe so.
Okay.
Yeah. So, yeah, I believe so. That's why I put them in there for you, so you can copy them down.
Here's my daughter's in nursing school, she loves it.
Oh, the ANP? Thank you.
She's like, wow, it's so much easier. I know.
After you practice a little bit, it is easier, isn't it? You know.
Yeah.
Don't try to take the quick. Oh, Don't panic. I swear, it'll be okay. Well, guys, I've really enjoyed you. I enjoyed having this class. It was fun. I appreciate your time. Good luck on your final.
Thank you.
My pleasure. Oh, I gotta do that. Yeah, I gotta shut everything up. Let me just stop the tape. I'll be right back.
I learned more on her AP lectures than I did with my AM.
I know.
We were talking about that the other night at
I'm
work.
like, are you kidding? That's why my daughter's having so much fun with it.
She's like talking about something like, she's like, oh, well, you should know something, and I need to go to school that long.